really quick. Make sure we can get started. See a few people missing. I'm going to give maybe another minute or two to see if we have the rest of the committee pop on, and then we'll get started. Okay, let's get started. Again, happy Friday. Welcome to our June meeting for the Mental Health Parity Advisory Committee. I'm going to start with taking a brief roll call. Angela Gamboa. See you. Carly Fleege.
Present.
David Carnahan. Dr. Don Fowles.
Here. Hey, Lynette.
Good afternoon. Elizabeth Paz. Okay. Jasmine Snipes. Carrie Stevens.
Present. Good afternoon.
Good afternoon. Kathy Busby. Monica Curry. Dr. Roger Wilson.
Good afternoon.
Good afternoon. And Mr. Thompson.
Here. Hello.
Good afternoon. Thank you everyone for joining us. We will jump right into the agenda. So we've been reviewing the website and we're looking at some of the definitions of, as far as what mental health parity is and how we want to describe it. And Erin, Mary, and I were reviewing some of it, and we want to get the opinion of, I don't know if Mary can pull up the website. Are we being too vague in our definition of what parity is? Is it too confusing? And this is going to also coincide with the community brochure, so we're tackling the two items at one time because we're extrapolating the information from our website into a community brochure to hand out to people that may not have access to the internet. So we want to make sure that we're clear on our definitions of parity, that's not too vague, or that it's not too jargony. I mean, we're all in the industry, so we understand, but if it's a lay person, we want to make sure that they understand it as well. Erin, I don't know if you have anything else to add to that.
Yeah, good afternoon, everyone. Mary, if you could pop over to, I think it's going to be maybe in the FAQ where we're, oh, is it there?
It's in the FAQ.
Yeah.
It's like the first two, like what is parity?
Yeah.
Yep, what is MHPAC? Yep, those first two.
So, and I cannot see that on my screen, so I'm going to have to pull it up on the website. So forgive me, bear with me while I do this myself here.
While you're doing that, if you can see it, or if you guys have been on the website, the words that we are concerned about is comparable,
Yeah.
and similar. We don't want
Yeah.
people to think that it means that it has to be the same on both sides, because as parity is, that's not what it means. So do we need to find different wording? Or as you're reading it, members of the committee, do you feel it's okay? Do you think the members that you're working with and the providers you're working with are going to be okay with that definition and have a clear understanding?
Yeah, specifically, thank you, Lynette. The specific sentence is the first one under what is parity. And it does say must be comparable. And it's that language in particular where we've been pondering whether that is clear enough to consumers, providers, and the public in general. So is there a more which in an effort to be brief and concise, have we lost something that could actually lead folks to be confused? Because we think a lot of folks probably think parity and comparableness means equal. And it doesn't necessarily mean equal. So in other words, if I have a copay for a psychiatric visit, it does not have to be equal to a copay for a medical surgical physician visit. So we just wanted to have a little bit of a dialogue about that language, because as we put together, as Lynette said, as we put together the brochure that we've been talking about, that's supposed to kind of help give folks a tool that to raise awareness about MHPAC. We just want to make sure that it's going to be as helpful as possible. So we'd love to have some dialogue about the words must be comparable here, if anybody's willing.
Well, I'll chime in. This is Don, and I think it's fine myself. I think we're left with the vagaries of language. It's never as precise as we may want, but if it were intended to say equal to, it would say that. I think similar and comparable about as good as you can get, but someone else may have a better idea about that too, but I think it's okay myself.
Right, this is Vista Thompson. I think that I exactly agree with those comments. And I think the federal regulators struggled with that as well, which is why they put all those illustrations in there. It's just really, I mean, it's hard for anybody to understand it, no matter how many times you read the rules, but it's the examples that give it life and sort of scope and meaning. So I, in a summary like this, I just don't know how else you tackle it without getting, eventually giving people examples so that they understand.
By all means, if they can always reach out to us via email or call us if they need further explanation, so we can try to make it as clear as possible. We don't want people to be confused.
Do Dr. Fowles or Vista, do either of you think that adding a sentence that says comparable does not necessarily mean equal would be helpful or harmful?
I was thinking exactly that comparable doesn't mean it will always be exactly the same or something like that, the same.
Yes, it's not a bad idea.
Okay. I think that would make me feel a little better. So if the advisory committee doesn't have any objection to that, then we can work on adding some kind of a little clarifying sentence there, and then we can pull that over into the community brochure.
I think it's helpful because that seems to be the most common misperception, is that it has to be exactly the same.
Right.
Yes, exactly. Great. Oh, thank you very much. Appreciate it.
Dr. Henning, one thing I've thought of is perhaps something, if you look at, I think in the federal act, it talks about, it essentially uses the term that the benefits can't be more restrictive. And I'm wondering if sometimes doing that, the comparable but not more restrictive, would be a way to further elucidate that.
And we received an identical comment to that, Kathy, in the chat.
I thought that, yeah, same person I think might maybe let me know that too. So
Good. Okay. Excellent feedback. Thank you.
Anyone else? Any comments on this?
I think it sounds pretty good with those revisions. I think that's, I mean, you can only do so much. And if it gets too long, then it gets too complicated. No one will understand it. So I think it's pretty good, actually.
Great, great. Thank you.
And with that, Mary, if you could pull up the brochure. So here's what we have so far. Definitely a work in progress. This is a trifold. So this is the outer, you can picture it, this is the outer edges. So if we were to fold it, the blue where it says Mental Health Parity and Addiction Equity Act, that would be the first thing that you would see. Where it has the Arizona logo, that would be the back part. And then the resources part would be one of the folds on the inside. So we felt it was, we have limited real estate on the brochure. So for resources, we wanted to make sure we gave the most critical for the counties that we are trying to reach. And so it has the crisis line that can direct them to the specific areas further if they need it. We just don't have the space to list every possible resource, but if they can reach the hub of the resources, they can get directed to the proper space. Any questions on this front page or this first graphic?
I'll come back to this maybe, but we have Denise who posted into the Q&A. I think she meant to put it in the chat about the federal parity law. And so her comment says the federal parity law says three things. Health insurance plans cannot have higher co-payments and other out-of-pocket expenses for behavioral health as they do for medical benefits. Health insurance cannot put higher limitations on the number of visits or days of coverage for behavioral health care than they do for other medical care. Health insurance plans cannot use more restrictive managed care practices for behavioral health benefits than they use for other medical benefits.
And I think that's important if it's, again, back to that more restrictive. If it's comparable. So if it's a comparable benefit, you can't have the higher co-payment. I'm inpatient, like an inpatient psych stay to an inpatient cardio stay. But I mean, obviously you do have some differentiations on the co-payment. They don't have them for primary care, but they do for all specialty. And so I
guess
is the
yeah, and I understand what you're saying, Kathy, but I guess that's my point. There needs to probably be a little bit more nuance in there because you're right.
I agree with you. If maybe it said they have the comparable benefits can't be more restrictive in their utilization or but they can't have higher financial, co-payments, co-insurance, something along those lines. The higher financial contribution as well as not more restrictive. I'm trying to think, medical management. If it for comparable benefits, does that make sense?
So in the FAQs further down, it talks about NQTLs and things like that. We could give some further examples further down the FAQs as it relates to being comfortable in what Denise is saying, so people are clearer on what that means. If you think that would be helpful, Carly or Kathy.
Yeah, I think so. I just think in the definitional part, though, we don't want to have somebody have to go further. I mean, but so long as they understand that it doesn't mean equal the same, but if you have comparable benefits, they cannot have more restrictions or higher financial contributions, and maybe something simple like that, and then further elucidate that elsewhere.
So we can put an example. I don't know if we can put it on this flyer. Mary, can you go to the next slide so they can see what the real estate looks like on the next page? On the website, we have the space to put an example with the, what's comparable, and here's the example. We can do that on the website. We would have to figure out how to navigate it on this part of the brochure.
Yeah.
So it's, and maybe, so the part where it says facts to know, that's taken from the FAQs, but it's just worded differently because you didn't have space for the question and the answer.
Yeah.
So we can find a way to manipulate that. So we just want to be, above all things, I understand that real estate is limited on the brochure, but we want to be clear. We don't want anyone to walk away with the brochure and still be confused. And so if we need to give an example, and if that is that section, maybe that's what we go with, and then they can call in for other FAQs and things like that. I don't know, Erin, how you feel about that.
So if we use like an example of copay, you know, a specialist on the behavioral health side and a specialist on the medical side, it should be the same.
Not necessarily.
Girl.
Not necessarily. Yeah,
I could give you an example of when the rule came out of a plan that we had where measuring parity, you know, each of the classes. So we had a benefit plan design where it was a copay for a primary care physician and coinsurance for a specialist. And so you were looking at the classification of
Okay, Vista, your mic keeps cutting out. I can't understand what you're saying.
You're only getting every other word, Vista.
Sorry about that. Maybe I like direct closer to, tell me if you can't hear me. We had a benefit plan. So maybe I'll put this on silent and call in. I was going to try and give you a benefit plan design example.
yeah. Vista, while you're doing that, I think that would be very helpful. But while you're calling in, so we get the best sound, I'll just make kind of a general statement. And actually, this discussion and Denise's comment is exactly what fueled my desire to have this discussion and about the language on our website and in the brochure. There are many circumstances based on the federal regulations regarding how insurers do that analysis to determine what their benefits are going to be, to determine what parity is, that can mean that you can end up with higher cost share for behavioral health services or substance use services than you do for med-surg in some instances. There's a very complicated formula that you have to apply. And you definitely do not have to have equal, this was the discussion about equal cost share for behavioral health and med-surg benefits. And we see it in the filings all the time. There are variations, and in some cases, the cost share and co-payments are higher for behavioral health than they are for med-surg. So Vista, are you with us now? Nope, she's still dialing. So, oh, and you know what? I think Monica Curry indicated that the password for the panelists didn't work when you dial in. Mary, I don't know if you have any tips about that.
Might be her phone too, the carrier sometimes. Don't
Yeah.
allow certain things.
So Vista, maybe we just need to have you talk really close to your computer.
You got closer to the mic, Vista, it became clearer and non-choppy.
Okay, we'll try it. Is this any better at all?
Yeah.
Yes.
Yes.
So we did have exactly what Erin was describing. It was the benefit plan design that would have enabled us in the category of outpatient in-network benefits. We had a copay for primary care physicians. We had co-insurance, I think, for specialists. And when you look at the claims analysis, what you have to do is take all of the claims that you have for surgical services, and you see, what's your substantial form of cost share, which is, 2/3 of what you spend. That's the form of cost share that you can impose on behavioral health benefit. And then once you get to that form, then you get the level. So we could have imposed, because of how much claim spend there was on specialists, it outweighed what we were spending on primary care physicians. We could have imposed co-insurance requirements on behavioral health, whereas we had a copay on the med-surg side for primary care physician. Or in a similar situation where you have one level of copay for a primary care physician and a second level of copay for the specialist. So when you look at the claim spend in that category of outpatient in-network benefits, your total claim spend is much higher for specialists just because they cost more. So even though I might, be going, why do I, have a $25 copay for a primary care physician and I have this $45 copay for my psychiatrist visit? It doesn't seem fair, but based on analysis in the rules, that was something we could do. And I think we don't think we have those same benefit plan designs anymore, but it really caused a dilemma. I think where we sort of voluntarily reduced the copay on the behavioral health side, not because we had to, because we chose to. But it is an example of how that it looks wrong, but it's correct under the rules or lawful under the rules.
So
I'm wondering if we could use. I'm wondering if we could use language comparable to, but not necessarily equal to.
That makes sense. I mean, I like that. I think the challenge here is, and there are many ways to do this, but one way that everything's so complicated to begin with in healthcare. So you get in these discussions, and unless you have very specific industry expertise and knowledge in a particular silo, it's very difficult to understand. So I think there's a way of doing this where you start out simple, and then if you want to get more detail, you can progressively. So on a flyer or something, it's very, very basic, so just about anyone can understand it. And it also serves as a way to establish a framework so that everyone has the same, level of understanding and everything. And then if you want to get progressively more detailed, you can, but maybe, and there's progressively more detailed materials, brochures, websites, FAQs, etc. But I think it's always good to start out simple, and it's not going to boil the ocean. It's not going to cover everything, but sometimes it's good not to try to boil the ocean too.
Agree. Absolutely.
Right, and we also want to make sure it's at, I think the standard is make sure it's at like a 4th grade reading level and not be too jargony in this, considering our audience that we're trying to reach.
But we also don't want to leave people with a misimpression. We don't want to mislead folks into thinking that parity means something that it doesn't, because we're also telling folks to make sure you appeal, make sure you file complaints. And if folks have a general belief that why am I paying a higher copay for inpatient or cost share for an inpatient mental health or behavioral health benefit, and my copay or cost share for med-surg is lower, that's not parity. And it may not be, but it may be as well. And so we just don't want to make it so simple that we lead people to misunderstand what it is. So I think some of the suggestions here about ways to qualify the statement are excellent, and I think it'll help a lot. I also wonder if we might, maybe for the next meeting, the department could put together some examples of the substantially all and predominant test, and some illustrations for you. And Vista, if you want to do the same, some examples from your end, that might help some of the committee members better understand kind of the nuances of what we're trying to parse through.
And Erin, I think Tim made a good comment. I mean, kind of back to the same thing about no more restrictive, that kind of expands what that means beyond med management to maybe take a look at. That makes it simpler.
This
Yeah.
is Dave Carnahan. Just one point I wanted to make. I agree with Don. I think if we have information here and then there's someplace else for them to go to drill in, because there is so much detail, I really think that's important. I like the location or the address for it. I'm just wondering whether we'd want to do more of a QR code so they can use their phone and just swipe over it and go right to that site and just make it real easy, since it is a long address. So just a suggestion.
I like the QR code idea.
Do we know how to do that, Lynette?
I will check with Amanda and IT to see if we have that capability, but I do like it. That is the way of the world. If you go out to a restaurant now, you don't get a menu, you get a QR code, so.
That's right.
Right?
Just don't have to generate one.
Yes.
Stay
I
with
would
the time.
I would recommend, this is Carrie, so I was going to say, I would recommend the address and the QR code, because I think this is for the folks that might not have Wi-Fi. And so you're in a place and you try to utilize your phone to get in Wi-Fi, you might not be able to access it. So I would just recommend both.
Good idea.
We'll just add the QR code, but we can keep the address.
Yeah.
Great feedback.
This, just so everyone is aware, this brochure will be in tandem with, we have approval where if I need to go out and do any type of speaking engagement to expand on MHPAC to certain areas, I can do that and hand out the brochure, but it also has some clarity around what we've just been talking about, comparable versus equal and things like that. So it's not just we're sending out information and not backing it up with some additional support.
You know, Lynette, on that point, I would, if the committee has input for us on ways that they think that we can, either groups that maybe we should be talking to, or ways that we can disseminate this brochure, you know, once it's finalized, we'll give it to all of you and you can disseminate it. But any other suggestions that you have on ways that we can make the most out of this would be welcome.
You know, I know you can't do it in a, a brochure that you hand out, but it might be possible to do it on, the online version. But you talk about in the second paragraph in the middle column is complex. So if you were able to link to, here are some examples, so they could, look as they're reading. Like I said, it doesn't really help so much when you handing it out, but because it really, the only way to get it is to look at some of the examples.
At a minimum, we could add something that said, for more information or for examples, visit the department's website. We could get them there, or another QR code.
Not that I want to make the brochure more difficult, because I know people are not going to read a whole lot if it's too wordy. Are we being too simplistic? Excuse me. Do we need a small booklet versus a pamphlet? Like people have their member handbooks. Do we need, and maybe not, because again, people take stuff like that and just toss it to the side.
Yeah, that's my concern too. The longer it becomes, less likely they are to read it.
Yeah, I agree.
Saying this facetiously, but everyone watches TikTok, so maybe we need to make it like a TikTok.
That's what we need.
TikTok. Yeah. Any other feedback on the brochure, the website, or the definitions? And again, like it's a fluid work in progress, so we will keep changing and modifying it as needed.
Just at the bottom paragraph under facts to know, it says early inpatient discharge concerns. I think we want to probably put an N there, I think.
The typo. Thank you.
That's all right. Actually, I thought it was a good play because it would sort of be like the hospital's inpatient trying to get them out. So in that way, it actually was a play on words that might work, but I didn't know if it was intended.
No.
And And this is Carrie. I put this in the chat, but I think the first line there says the mental health parity and addiction. It is missing the C for addiction.
Addiction,
first
yes,
line there.
another typo. Thank you. Excellent. Glad we're having you help us proofread. And I think I know when I read the appeals or complaints section, I feel like that might be an area where we can maybe simplify some things too. So if anybody has any comments on that section, we're amenable.
And this is Carrie again. I was just looking up the website. I don't know if it's, I'm not always sure how all this works, but the website, when I looked it up, it came up that it didn't work, but it was difi.az.gov/content/mental health parity 1. And so I don't know if the word content needs to be in there or if that will be changing. Like if we're updating it to take that word content out, but I would just make sure that the website is what it.
Oh, that's the main
needs to
mental
be.
health parity page. Yeah, it does have that in there.
I must have a different one. Yeah.
Yeah, see the URL. Okay. Great.
Anything else?
Okay.
Well, I appreciate everyone's feedback. We want this to be good, the product that we're sending out. So, next, I believe Jacqueline is on to give us a brief update on the suicide mortality review program from ADHS.
Yeah, hi everyone. I don't have a whole lot to update you, but I was telling Lynette that we have made some progress in terms of getting the program established. So as most of you know, we're using Prop 207 funds. So we just got the funding to be able to hire new staff. So I was able to hire a full-time program manager, Jessica Bell. Jessica comes to us from the Arizona Board of Pharmacy. She has a PhD in medicinal chemistry and a master's degree in public health. And I have worked with Jessica over the past few years on the opioid drug epidemic. She was the person at the Arizona Board of Pharmacy that was the manager of the controlled substances physician monitoring program. So she worked on the PDMP and implementing many of the processes for monitoring opioid prescribing by physicians. So Jessica is with us now 2 weeks. And then I was also able to hire an epidemiologist who will be working with us to pull the death data and to work on building out a data collection tool for the cases reviewed by all the county health departments as well as the state team. So that is progress since I think I met with you folks last. So I have staff on board. We are building out the program, creating procedural manuals, guidelines, protocols, templates for the county health departments, for the local community suicide mortality teams to use. And once we get those documents created, we will be meeting with the county health departments to do training with them and helping them establish the local county suicide mortality teams. A lot of the county health departments, we already work very closely with them on our drug overdose fatality review program. They all have overdose fatality review teams in place, and there's a lot of crossover and similarity with the suicide mortality review program that we will be implementing. So many of the county health departments will be using the same overdose fatality review team members, with perhaps adding a couple of different team members to their teams related to behavioral health or something more specific for mental health to address the suicide reviews. And so we're working on that right now. I also was able to draft language and for contracts with all the county health departments. We are sending the funding to the county health departments through an IGA, intergovernmental agreement. And we have an intergovernmental agreement, an IGA, with health departments currently. So that the suicide mortality review funding will run from July 1 through June 30 each year. So it's going to be on the state fiscal year. And so we got the contracts are out, they're in the AG's office, and they should be going out to the local county health departments within the next few weeks. We also have been having one-on-one conversations with the county health departments regarding their capacity to do suicide reviews. And so we're working with each county health department alone, and then we'll be working with them as a group when we start doing our online training. So that is about it as far as the updates go. Do you all have any questions or?
Jacqueline, just one question. Is the county looking at psychological autopsies as a part of suicide investigation?
Yeah, so and that's what we do is we create a case narrative. So for instance, with the overdose fatality reviews, we have created a template that is a really comprehensive picture of the decedent's life. We pull medical records, Department of Child Safety records, DOC records, you know, any type of criminal justice records, medical records, behavioral health records, so that we can put together really a comprehensive picture of the decedent. And yes, we will be doing the same thing with the suicides to put together, you know, what was going on in their life, you know, where were there possible points of intervention or prevention that could have been provided to this person. And then, you know, some of the local counties will be doing probably family interviews. I know with the drug overdose, some of the smaller rural counties like Navajo County and Yavapai County, they are doing a reach out to the decedent's family members and doing some interviews of the families, and which even adds, you know, additional further information. So in answer to your question, yes, we will be doing those.
Thank you.
Yeah. And we work closely with the ME offices. You know, many of the ME offices are overworked, understaffed, under budgeted. So, you know, we work with them on the fatality review programs now and have MEs as part of the review teams. So I think, and again, the benefit with the local teams is that they work typically fairly closely with their ME office. And some of the ME offices are even located within the county health department building. So, you know, they're able to get information from their MEs fairly quickly when it comes to these types of cases.
And there's a common definition of suicide. Is it state defined, or does each county define the definition of suicide?
You know, we haven't gotten to that point, but as a state, I think it'll be the state, because what we typically do is we will be pulling the death data, you know, the death through the vital records at the Department of Health Services. We'll be pulling a lot of the death records for the local county health departments, and we'll be providing them to the county health departments.
Any other questions for Jacqueline?
I'll have to come back in a few months when we're making some more progress and we've got the program manuals and templates and teams started. So
Thank you so much. I'm excited to see some of the data that you share with us.
yeah.
Help make some changes.
Yeah, it's always nice, especially to have local, you know, the benefit of having local teams is that they can make recommendations that are particular to their communities. Because what I have learned through the overdose fatality reviews is that all the counties are very unique and different. And it also encourages collaboration amongst their community, you know, representatives that work in behavioral health, in the ME and the EMS and law enforcement, and all of those different entities coming together. It's a really good thing to foster that collaboration. So,
Any more questions for Jacqueline?
well, thank you, everybody.
Thank you for sharing with us.
Oh, sure, no problem. Have a good rest of your day.
So have a good weekend. Stay cool.
Okay, thank you. Yeah, hardly, but yeah, thanks. Bye-bye.
Next, as you know, last month was Mental Health Awareness Month, and the department did. Hopefully, you saw them on Twitter and LinkedIn. We had some retweets from the governor's office that was very exciting. We continue, just because of where we are in the world, to want to stay on top of mental health awareness. So Dana Flannery from Access has some updates and a presentation on what's happening from the access side of things. As the director is a advisor to us for our committee, and how we can help continue to support them with their efforts in mental health awareness as we move forward and get ready for September for Suicide Awareness Month. So Dana, if you're ready, you can take it away.
Sure. Thanks so much, Dr. Hennigan. Good afternoon, everyone. I'm Dana Flannery. I'm the Senior Policy Advisor for Director Snyder, as well as the Assistant Director of our Community Advocacy and Intergovernmental Relations Division. So all things with our federal partners, our tribal partners, our communications, and then our advocacy areas. So our teams had a lot of work to do in May for Mental Health Awareness Month. So just sharing some high points. This is not meant to be an exhaustive presentation of what we did. And just a disclaimer, this is for the Medicaid work here in Arizona. So again, we represent about 2.2 million Arizonans and provide insurance and Medicaid coverage. So right there, we kicked off the month with our recognition of Mental Health Awareness Month, noting the proclamation and some of the efforts and some resources for individuals. And so that came out of our news and updates. So lots of people subscribe to that. Next slide. We were very busy on social media. We have a wonderful social media team of 2, and we looked at Mental Health Awareness Month, and there was also the overlap of National Prevention Week, Children's Mental Health Awareness Week, and then all of the efforts we'll be doing with Resilient Arizona, and we have done. I have a little video on that for you shortly. But again, here's just some of the posts that we were doing, and then I split them out by different methods. Okay. So here was some of our action on Twitter. Our most engaged post was that initial post that had almost 1,200 impressions, and our top 3 most engaged tweets were related to Mental Health Awareness Month. So a lot of movement on Twitter, some facts, acknowledgement of the month, other resources, and linking up. Okay. Here's some more. So as you can see, they were very busy. You really letting everyone know about Mental Health Awareness Month, some of the resources that they can tap into, etc. Okay. Facebook. Access is very new to Facebook. That was a new endeavor that we took on recently, large in part due to the pandemic, because it was a really easy way of connecting with our members, and not as many of our members are on LinkedIn and Twitter. And so really just started launching our Facebook, and we had a very, very busy month on Facebook simply due to the mental health month and all of that campaign. And so our 1 in 6 youth fact was our most engaged post on Facebook. Okay. We also were very busy on LinkedIn. Our most engaged post was the original post on the 1st of May, noting that it is Mental Health Awareness Month, but also highlighted some other peer-to-peer physician programs and other efforts going on with relation to mental health. Okay. And then here's just some of the stats that we look at. So how many posts we did on each, how many shares, and then other resources we were able to push out. So tried to stay nice and engaged and busy that month to really highlight. Okay. So while we were busy on social media and pushing all that information out, I'll just go over a couple other mental health activities that we focused on throughout the month of May. So some of our suicide prevention efforts for Mental Health Awareness Month, we hosted a media training for state agency public information officers as it relates to the reporting of suicide. We also presented in 2 community groups reaching over 100 Arizonans with suicide prevention messaging, hosted the first county health suicide prevention work group, and 7 counties were represented. And then we organized the first 4 corners suicide prevention in a while. So we're going to be going back to quarterly meetings for and finding out current projects, listening to what's going on in other states, and collaborating where possible. Okay, so WICHE, some of you may be familiar with WICHE, others not. It's the Western Interstate Commission for Higher Education. We did a partnership with them for some trainings. And so we have a lot of things in our services for our members, especially those living with a serious mental illness, as it relates to assertive community treatment, permanent supportive housing, supported employment, consumer operated services. And so while those terms are thrown around a lot and people understand what may or may not be in the system, it was a great opportunity for them to provide some evidence-based practice trainings as it relates to those. And so they did that throughout May. Okay. And then we're continuing our community conversations. This happens through our Office of Individual and Family Affairs. Our Office of Individual and Family Affairs is comprised of either members, so peers that are living with a behavioral health situation, or family members. And so a lot of the people in that side of our office are, again, family members with lived experience or peers with lived experience. And so we had a community conversation through OIFA focused on trauma-informed care. That was well attended. And we had John Anglin from Arizona Complete Health, their special projects advisor, presenting real-world trauma-informed care. So that was wonderful. Okay. And then our Peer and Family Career Academy. So when formerly Department of Behavioral Health Services and now Access has really helped to sponsor some of the work to look at the peer supports in our workforce. And so again, those with lived experiences delivering services to members, and that model, and what's next for peer supports. And so for peer reports, recovery specialists, if you really want to look at career paths and what can we do. So if I have an interest per se in forensic peer support, or someone that has wanting more of a supervisory track in my career. So really looking at an academy. And so we are working on transitioning that to the community after quite a few years with those projects being led out of Access and a contractor. So that was super exciting. And in May, we announced some next tracks. Okay. Our OIFA newsletter, as I just mentioned, our OIFA department, they're wonderful at staying connected with the community, and we have used them a lot throughout this last year, especially to stay in touch with our membership and be cognizant of the needs. And so they have a wonderful newsletter that goes out every Friday. If you're not plugged in, feel free. There's your QR code that you guys were talking about earlier. I love the subscription to that myself, and I work at Access and live and breathe it every day. But it is really neat to know what policies are changing, contracts, new things going on in the community, and they really spread the word about a lot of community engagements that really have nothing to do with Access as well. So it's a good blend. So if you have any interest, feel free. Okay, so on the horizon, what's next for us? I did just want to note, given the times right now and everything that's going on, we have a couple things on the horizon, including we submitted at the very end of May a wonderful waiver amendment that looks to really expand on the work that we've done in permanent supportive housing here in Arizona. So right now we have over 3,000 in permanent supportive housing programs. And so looking at the extreme savings that causes for our system, but moreover, the lives that it's able to change. And so looking at recovery a little bit more holistically than just behavioral health or physical health, but also looking at all the social determinants of health that have a huge impact on our lives and what our recovery can look like. And so a lot of data was submitted with that waiver submission, including showing 31% reduction in ED visits, 44% reduction in inpatient admissions, 89% reduction in birth admissions, and 45% reduction in cost of care. So we've submitted that to CMS. It's open for federal public comment now, but looking forward to starting conversations with them. We also have a lot going on. I'm sure you're well aware of 988 efforts upcoming as it relates to taking the National Suicide Prevention Lifeline and having that 3-digit number and what that looks like in the state. And so looking at, we have a planning grant, and we've conducted quite a few forums, and we kicked those off in May during Mental Health Awareness Month to get some feedback on our current system, because again, our crisis system that Access is responsible for is for everyone here in Arizona. So that extends beyond Medicaid. And so looking at how we can align National Suicide Prevention Lifeline efforts with Arizona's crisis system. And then we also have a continuation of the crisis counseling program, which we'll have a video in just a moment. And then all things American Rescue Plan Act. We did just launch our webpage. Some of the opportunities through the American Rescue Plan Act do extend beyond the Medicaid population, especially the block grant through SAMHSA. We just had a wonderful forum on that last night. And so we've launched that page. It talks about all of the variety of opportunities that we're navigating for our system. And so whether it's for home and community-based services, the block grants, and then upcoming some American Rescue Plan Act guidance for mobile crisis services and opportunities. So if you want to stay in tune with those, that would be wonderful. We would love to see you at the forums and hear your ideas. We also have a public input mailbox, publicinput@azaccess.gov, if you have any ideas. And some of those turnarounds for American Rescue Plan Act are very, very quick. And so really looking to get that feedback as soon as possible. Okay. And then this is just a wonderful video done with the crisis counseling program that Access has been assisting with throughout the course of the pandemic. And so did a lot of marketing towards this through Mental Health Awareness Month and every month, but really focused on it then as well. So if you want to show the video.
It'll just take 1 minute. I'm going to need to switch some settings.
Sure. So while you're doing that, I'll just say that the FEMA, so Federal Emergency Management Agency, and the Substance Use and Mental Health Services Administration, SAMHSA, approved that 6-month extension recently for the crisis counseling program. And so that's through Resilient Arizona. So a little bit different than Arizona's usual crisis system. This is really specific to the pandemic. And so it's in response to the COVID-19 public health emergency. So And if not, no big deal, Mary. We could always send out the link to the video. It's on YouTube.
Yeah, unfortunately, I don't think there's going to be a way for me to share it with you hearing the audio. So I think we will have to skip it. Sorry, Dana.
That's totally fine.
All right, let
Yeah,
me
if
get
you
back
want to
to your
drop the
slides.
link to individuals in the chat, that way
Will
people
do.
can watch it on their own time. It is a wonderful video. I'm very proud of them. They've been doing a great job. And so my last slide is very overwhelming and has a lot of statistics on it, but it is in relation to the CCP, the Crisis Counseling Program. So don't need to go through that in detail, but it really just looks at, you know, what are we able to reach with this? Oh, okay. So it talks about what it is, some of the feedback we've received directly from FEMA and SAMHSA, which was wonderful, how many participants, top risk categories that we're seeing, top event reactions, and referrals provided. And again, this is for anyone in Arizona, so this is not specific to Medicaid, and has been really rewarding and wonderful work during these tough times. And then lastly, we always have to look internally at our own agency. And so we have, over the past couple of years, really focused on making sure that we have trainers in our own agency that are able to provide mental health first aid training for the Access staff. And so in 2021, so far, we've hit 88 staff trained in mental health first aid, and we continue to do so. So it took us a while to get the virtual allowance during the pandemic, but now that that's up and running, both of our trainers are back at it. And so since the virtual, we've done 120 virtual. And it's been a great success. Any questions for me?
No,
Just
Dana,
had a
it's great
comment.
work. Yeah, just great work. Kudos to Access.
Thank
Yeah, I was
you.
going to say the same thing. I mean, it is remarkable, and I, you know, it's really great to see, Dana, because I know I'm totally biased here, but not some ways not, because I see, you know, the rest of the country, Medicaid agencies and others, Access is a leader in this in behavioral health. They really are, and other states look to them, and it's remarkable the amount of work that you're doing. And I just, you know, the mental health first aid training is fantastic. The suicide prevention stuff is really great, and it's you know, we got the governor's support on that. He would, you know, represent it during the suicide week in September. And the last thing, the crisis counseling, it really is very, very important. Unfortunately, in our mental health system in our country, the whole counseling aspect has kind of gotten lost in a lot of case management and prescribing and everything. And it's really good to see that you guys are focusing on that. So I just really, you know, kudos, as Roger said.
No, thank you, both of you. I appreciate that feedback. And I would be remiss to not mention, we also do Safe Talk training, and many of us have also been assist trained, but we had to put that on pause just because there's no virtual platform, and we are still virtual at this time.
Dana, I would echo both with Dr. Wilson and Dr. Powell said. So, and mental health is at the forefront of conversation globally. And so I'm excited that we are partners and can push forward the work. A lot of us on the call have been in the trenches for a long time on the behavioral health side and trying to get it recognized. And it is a serious issue. And I think this is our moment with the way, unfortunately, the way the world is, but we have to strike while the iron is hot. So thank you.
Yeah, very trying times, but very exciting opportunities lie ahead. So
Absolutely. Any questions?
well, thank you so much for giving us time.
For Dana? Thank you, Dana. Anything else for her before we move on? Awesome. Okay. Next area of business is the update on the proposed rules for SB 1523, better known as Jake's Law. We had substantial comments from industry providers, family members, and we are moving forward. So if Mary Kaczynski is on, or Aaron, if you want to go ahead and kind of give a status update of where we are.
Sure. This is Mary Kaczynski. Thanks, Lynette. Yeah, we did have substantial comments, and what the rules, guiding rules say is that if you are going to make substantial changes to a proposed rulemaking, you have to either issue a supplemental rulemaking, which is like starting a rulemaking over again. So you publish a new proposed rulemaking, and then you open that for comments, and it's like another round of what we went through. Or the other thing is you can terminate the current rulemaking and begin a new rulemaking. So there's a timeline on that that's imposed by law. And so we decided that because of the timeline, we would not have and there was also, besides the comments, there was also some new federal requirements that came out, reporting requirements for insurers that came out. And so we made the decision to terminate the current rulemaking, and we will initiate a new rulemaking. The termination of the rulemaking will be effective in about 3 weeks. It takes 3 weeks for the Secretary of State to publish the termination, but it will give us an opportunity to begin the process again and try to accommodate the concerns of both all the stakeholders, both the interested parties on the family side and the mental health provider side, and the insurance companies. So that is our plan. I don't know. I think we have been discussing conducting some more listening sessions, but maybe having both parties attend so that we could get a better feel for where we can go with writing the rules. And we will also have an opportunity to review the federal requirements to see what those are. And we don't want to create unnecessary duplication for insurers, because rules are supposed to be the least onerous regulatory burden on a regulated party. So we are going to go forward on a new rulemaking, probably starting in a couple of weeks here. So, Aaron, did you want to make any other comments on that?
No, I guess the only other comment is just to say, I don't think we have yet have a good handle on when the next proposed rule or draft rule will be available, but we will start working on it post haste, and there will definitely be lots of opportunity for input, just as there was with this rule. There will, once the proposed rule is out there, there will be opportunity for public comments. And if we have time to do listening sessions, that's another option, as Mary mentioned, or again, if there's time, there's also the ability in the rulemaking procedures to issue draft rules before we actually publish a proposed rule. So that's another procedural option we have, but we are way behind schedule at this juncture. So, we need to keep the ball moving here. So that'll all have to be taken into consideration as we decide what to do going forward. So, but that's the update on the rule.
So, just a couple comments on that. I mean, I can understand, especially some changes that we need to relook at these. One just a concern and just a kind of a question is, I think first, since we are kind of now a little behind the 8 ball, anything we can do to expedite that process, I think would be good, while also allowing obviously people to have time to review and comment. But part of that's a question: are we going to scrap everything, or is this looking at what we have now and trying to make revisions, additions, etc., to respond to some of the concerns and the new federal regs?
I think the plan at this point is I don't think that the entire rule package would have to be scrapped. I just think that we would need to rethink some of the reporting requirements, basically.
Okay, I just said, since we put a lot of work in that, it'd be nice, some of
Yeah.
that work still kept, and just what's problematic, we address.
Yeah. And mostly I believe it would center around the reporting requirements. And so, yeah, I think that's where I envision most of the revisions coming, is in paring down some of the reporting requirements.
Thank you.
Hi, I just wanted to, I managed to figure out what was my issue with my computer, so I'm really on for real now. Thank you for, thank you. Thank you for that update, and I really appreciate the department's thoughtful approach and doing this the right way, not just rushing something to get it out there. And we fully recognize we want to be timely, but we also do want this to be meaningful. So I really appreciate the department doing that. I think there were a few areas in the proposed rules that really merit an additional round of discussion to make sure everybody's on the same page and that we're providing information that actually is meaningful, does provide the transparency we want. So I would just really recommend, if there's an opportunity to do another quick round, it doesn't have to be dragged out or long, but a touch base with a lot of the folks that provided that a type of feedback, so that we can hash out and make sure we're understanding what is needed, what kind of information we're asking for, what can be provided, all that kind of good stuff. So if there's an opportunity for that, that's a recommendation.
Thank you.
Thank
Monica.
you.
Any other questions or comments for Mary or myself or Aaron?
This is Don. I just wanted to second what Monica was recommending. I think it's a good idea. Look, this is an important issue, and I think most of us want to, recognize the importance of people getting mental health care in our state and in our country right now with all that's going on and everything. But I think everyone that I've experienced on our calls has been really well intended. We may come from different perspectives, but I think it's really bringing everyone together to get everyone's input, that it's important to do something, but it's important to do something right. And what the last thing we want to do is do something that just, creates other problems that are unnecessary. So I think a little, hopefully we don't take forever or anything, but I think taking a little time to do this right makes a lot of sense.
Dr. Fowles, I don't have forever.
There you go.
Anyone else? Aaron, do you have anything else?
Thanks, Lynette.
Thank you, Mary. Have a need for an executive session. Our next meeting is in August, but if we move quickly forward with any of the rules and stuff, I will call a meeting in July if needed. Definitely any future topics that we want to talk about. I have Suicide Prevention Awareness Month, which is going to be coming up rapidly, and we want to continue the momentum that we did from May with Mental Health Awareness Month. So we'll be moving forward with those topics. Any other topics for a future meeting in August, other than the rules and Suicide Awareness Month? Well, I will give you 15 minutes of your life back. You can enjoy this 118-degree heat and stay cool. Anything else before we dismiss? It's good seeing everybody. I feel like it's been forever.
Yeah, you too.
Thank you.
I appreciate everybody
Thank
taking
you.
time out of their day to participate, and we will see you in August, if not sooner. Stay safe, stay hydrated, and stay cool.
Thank you so much.
Thank you.
Thanks a lot, Lynette. Y'all take
Have a good
care.
weekend.
You too.
All right. Bye-bye.
Bye.